So, welcome everyone. I'm Susan Wehry. I'm the director of Aging Maine, Maine's Geriatric Workforce Enhancement Program, which is, as I think people know by now, a HRSA funded grant, and it is HRSA who is sponsoring this and all of our previous Dementia Reconsidered programs. I am joined today by Anne Wyatt, whom many of you had an opportunity to meet at our last Dementia Reconsidered just a couple of weeks ago. So welcome, Anne, and thank you so much for being here with us again today.
Thanks.
I just want to confirm that everybody can see the slides. If I could just get a thumbs up. Thank you, Anne O'Sullivan, right there in the center of the screen. Nice to see you. And thanks for that confirmation of the slides being available to you. All right. So without further ado, I would like to get started. My goal today is really to promote the practice of compassion and to share some strategies with you as to how I think that can be done. And I think it'll become very, very clear to you why this has become such a passion of mine and why I think it is absolutely so important that we nurture, revitalize, activate, nurture compassion in these particular times, in all times to be sure, but especially now. So at the end of today's conversation, my hope is that you too will be able to discuss the difference between empathy and compassion with your family, friends, and coworkers, or with whomever you want. But the main idea here is that I hope that you will want to, because I think once you start thinking about and talking about compassion, you too will begin to look for ways to actually activate it in your own lives and in your workplace. And we're going to talk about some skills and very specific strategies on how you might do it. So as we always do, we will try to touch your head, try to touch your heart, and then give you some practical applications that you can take with you. I want to start by thanking you for being here. I know you could be anywhere right now, and so I thank you in advance for your active participation, and frankly, all you do now to make the world a little better place. I'd like to tell you why I'm so passionate about this right now and to also make a dedication. A very dear friend and beloved mentor of mine died a couple of weeks ago, but not before she had one more lesson to teach me, and it is to her that I dedicate this program today. I went to see her several times over the last 6 months back in Vermont, and on one of those visits, I arrived about a month after Christmas. She was not doing well. She was in a nursing home. She had had a fall. She had broken a hip. She was there for rehab. She was hoping to move on back to her assisted living facility, but she was not doing well. And when I arrived to visit her, I found her looking rather unkempt, food down the front of her shirt, a little out of it, I guess would be the non-clinical way to put it, not asleep, in a wheelchair, and sitting in a day room that had for its visual features dead poinsettias, half-done puzzles, games strewn about, a television playing a Spanish language channel on which the image, when I walked into the room, was of a very distraught young woman knifing an unfaithful lover. 4 other residents were in that day room, calling out for coffee, for attention. There was an unspecified bit of soil on the floor, and it broke my heart. One of the great things about a broken heart is that if they break in just the right place, they break wide open. And in the midst of all of that, where my first impulse was fury, was rage, was anger, was sadness, was brokenheartedness, I looked at all of us in that room, and I saw a staff that had been dealing with COVID for 2 years. I saw residents who had not seen their families for a year and a half. I saw so many reasons for people to have lost their capacity for just a little kindness, just a little smile, just a little, can I help you with that? Can I get you a cup of coffee? And I realized that I needed to renew my efforts to create conditions in which it is easier for compassion to emerge, rather than for us to rely on, full staffing, everybody happy, nobody afraid, everyone feeling totally loved, well-fed, and well-dressed. Those aren't the conditions in which we need to reach in and find that capacity for compassion. The conditions that I was in were exactly where compassion was needed. So let's take a look today at what that is, how to get it, how to be reminded of it, and how to let it emerge. And this one is for you, Janice. So, how about you guys? I'm going to do my first poll. I'd like to know who's here and how you're doing. You'll see the first poll here asks you to answer two things. The first question here is about who you are, what your role is, if you will, in the human services world, and then how long you've been at it. So you'll see that the first is the long-term care professionals, and that's all of us who work in long-term care, regardless of what your capacity is in that particular role. Social service, again, in any setting, whether you are a healthcare professional but not currently working in long-term care, chaplain, and so forth. And then if you would please, as a second choice, just indicate how new you are at this or how long you've been at it. And your choices are less than a year to 5, 6 to 10, or more than 10 years. I'll let the poll go just another minute. We have about 52% of participants who have answered, so I'll give the rest of you an opportunity to do so as well. And then the second part of this questionnaire, you've already seen it, I had to scroll it up on mine, is how you're feeling right now. And we've just been at this for about 1:40. About 80% of people have answered. I'll give it just another 15 seconds, and then I'll share with you the results of our community today in this virtual world. All right, that's 80% of you. Thank you for answering. And here's how it looks. Almost 40% are from long-term care. Welcome to everyone. And about a third are social service professionals. We have a care partner or a person living with dementia or another chronic serious illness. I'm not sharing the results. There we go. You can see now for yourself who we are here. And you'll see, just as we'd hope, that many of us are working in long-term care, because this is going to have a lot of tips that are really designed for you. And over a third of us, just a little over a third, are feeling grateful today. Some of us are tired. Many of us are just curious, and some of us have another word for what they're feeling, but no place to type it in. And so I welcome all of it. And here's your first lesson in cultivating your own compassion. One of the things that's necessary for the cultivation of compassion is self-compassion and self-attunement. One of the things that allows us to, in fact, be compassionate, to feel compassion, is the capacity for emotional regulation. It is important, and it was important for me in the story that I shared with you, to know It wasn't that hard, but to know how furious I was, how hurt, disappointed. I had been Commissioner of Disabilities and Aging in Vermont, for Christ's sakes. I thought I'd fixed all that. It was supposed to have been better. So I had to deal with my own self-recriminations. I had to deal with my anger. But just think about how all those feelings would have been in my way if I hadn't simply named them and then been in a position to choose how I wanted to think, to choose how I wanted to behave. But you can't get there unless you've got some emotional regulation skills. And you've just practiced the first one. Know how you feel. And know also, paying attention to how you feel, that all feelings are fleeting. They come and they go and they change. Sometimes when I'm doing this poll, people say, I don't have just one feeling. I said, of course you don't. None of us have just one feeling at any given time. Pick one, catch it, put that one down, and then pay attention to the fact that it's not your only one. This is how we begin to attune to ourselves and to learn how to prepare ourselves to practice compassion. So what is this thing I keep referring to? What is compassion? Well, as you can see there on your slide, compassion comes from a Latin word, compati, which means literally to suffer with. Compassion, as we now think of it, is a multi-dimensional construct. It has many elements, and it has been the focus of really pretty intense study in the neuroscientific community for about the last 2 decades, as we have come to appreciate that compassion plays a very specific role in our evolution as humans, as Homo sapiens, and is subserved by very specific neural networks. Now, why do I say that? I say that because when we know how something is working or where it is working in the brain, if we don't want to rely on 3,000 years of wisdom traditions, starting with the Tao and moving through Buddha and Hindus and Jesus and everybody else, if that's not your thing, wisdom traditions, take it from me, the neuroscientists have also confirmed that compassion is good for us and good for the species. So it's probably a little bit more than just having the feeling. There is a cognitive component to this. There is an awareness of the suffering of others. There is an affective component that we need to be moved by the suffering of others. Not need to be, but we are moved by the suffering of others. But the thing about compassion is that it also has this intentional component. But the thing about compassion that is different than just feeling for another, feeling into, the thing we mean by feeling with, is that it also carries with it the intention, the wish, the desire to relieve that suffering. We want to be of help. We want to be able to relieve some of that suffering because we know it's good for us and we know it is good for others. And then the final component I think that most people talk about is this motivational component of compassion. It's a readiness to relieve. And here's a critical concept to keep in mind. The thing about compassion being this kind of multi-dimensional construct, this head thing as well as this heart thing, is that even when we are unable to act in that moment, the wish to act, the intention to act, carries with it the positive benefits to our brains. So compassion is good for us as well as good for others. There are so many interesting studies that have been conducted on empathy in chimpanzees and bonobos, and it looks like compassion may actually be part of the endowment of the higher primates, of which we used to be worthy of being called. But the higher primates really may finally or may ultimately decide that survival belongs to the kindness. And compassion, as defined by my colleague Agnes Wong, is a sensitivity to the suffering of self as well as others, with a commitment to alleviating, and she would add, or preventing it. Or as I would say, quite simply, compassion is simply When you see suffering, you want to do something about it. And the thing you want to do is to make it go away and not come back. So that is how I'm using the term compassion. And the question that is of great interest to me and others, I think, is to ask whether or not this capacity is an innate capacity. Does everybody have it? Are we born with it? Certainly, we all know some people who are more compassionate than others. We know people who have honed this to a fine skill. Not even a fine skill, it's a way of being. And we know that we are in the presence of compassionate people, we feel better. We know that compassion serves the person, they seem to feel better, and we feel better. Now, I've just read a wonderful book that I'm going to recommend to you called The Art and Science of Compassion that makes a very compelling case for the answer to this question being a resounding yes. Compassion is innate. And she presents in this wonderful primer on compassion all of the physiologic evidence, the biological evidence, the evolutionary evidence, the psychological evidence, and the spiritual evidence that compassion is an inborn human capacity, and makes an equally compelling argument, as does the Dalai Lama, that compassion is essential to our survival. Not a luxury. It's not a feel-good extra. It's not a bumper sticker. It's something we need if the human species is going to survive. So, some of you might be wondering, I hope you are, well, what's the difference between compassion and empathy? Empathy is a related feeling state, also with a couple of different dimensions. Empathy is from the Greek empathia. Greeks probably say it differently, but that's how I'll say it. Empathy is a feeling into the other, as opposed to compassion being described as a feeling with. Empathy, like compassion though, does have a feeling into another's feelings, a sharing of that physical or that physical and psychological state. I feel your pain, as it has been said. Empathy also, however, has a cognitive component in which we say, I know, however, that that's your pain, not mine. And I might have an inkling, and I should ask you, but I might have an inkling as to what the source of your pain or suffering might be. And I can create for myself a mental picture, both of your pain and suffering, as well as that not being mine. And if you think about it, that's actually a pretty nice, it's a pretty nice evolutionary perspective to have. Because one of the things that we know is that lower animals, so-called, also seem to demonstrate empathy. You can see this in babies crying when another baby cries. You can see this in the animal kingdom through emotional mimicry. So we see it in a lot of places, but what seems to distinguish Homo sapiens is this mentalizing, this perspective taking, that we know there is a self and an other. But empathy is probably a precondition, a primer, if you will, for compassion. And it might look like something like this. So a wonderful article in Current Biology, probably a decade or so ago, looking at empathy as sort of the root or the first step in compassion. But you can see that empathy can go in a couple of different directions. Empathy can go in the direction of empathic distress in response to the suffering of others. And we know many times how easy it is for people to get caught up in empathic distress. I cannot stand to see someone in so much pain. It hurts me. it makes me so sad, I can't. Whatever that distress feeling is, empathic distress is experienced as stressful as if the feeling were yours, as if it were happening to you. And sometimes that is taken on, particularly I think by healthcare workers, as a sign of just how caring they are. And I'm not saying that it's not a sign of how caring someone is, but it is, without a doubt, particularly in these times, a path to burnout. Because when our distress becomes about how bad we feel in response to the others, it inevitably leads to poor health and burnout, and ultimately leads to our withdrawal and non-social behavior. We can only look so long at the suffering, for example, right now in the Ukraine, without wanting to turn away. And if we make it about how much it hurts us, then in fact, it will lead to empathic distress, burnout, turning away. And we see this a lot of times in large-scale disasters, because after a while you sort of can't take it anymore. It's that kind of state. The other thing, though, that empathy can do is prime the pump for compassion, where our sense of separation and our sense of whose suffering is focused on the other. And in that situation, it generates much more of a loving kind of feeling, such a strong desire to relieve that suffering of the other. And interestingly, compassion, unlike empathic distress, is actually associated with good health, not with caregiver burden, not with caregiver burnout, not with caregiver, poor health outcomes. Compassion is actually associated with better health, better physical health, and better psychological health. And when we can take our empathic response, our empathic concern, and use it to act with compassion, then in fact we don't turn away from the suffering of others, but we approach it. Now, it doesn't mean that we stick our hands into everything or our face into everything, or that we're always in a doing mode. Being compassionate doesn't mean, here, let me help you. That could be when helping hands harm. Compassion means being with another person in their suffering and attending to them, asking them, attuning to them as to what would be most useful in that situation. So it inspires this kind of pro-social motivation as opposed to withdrawing. This is why I don't like the term compassion fatigue, because it doesn't fit the facts. And why I, and I think some others, Dr. Wong for sure in her book, thinks that the term empathic fatigue or empathic distress is more accurate. Now, this is frankly more than just semantics. This is not just like getting the word right. This is really about recognizing that compassion confers physical and psychological benefits, and that it's different than empathy, and that while I think that it is innate, learning to work with it, using it, having it at your disposal, does take some work. And I think if we don't make those distinctions, we may miss an opportunity to actually cultivate our compassion in the face of stopping at cultivating empathy. And I've already mentioned before, another reason I think compassion fatigue doesn't work is that if you measure empathic distress, you find that it's in a different part of the brain than when you measure compassion. And so that speaks to this being different. And people who are truly compassionate speak to compassion and this wish for others to be free of suffering as actually a wellspring of energy that never runs out. I don't know who else there, maybe Mother Teresa, maybe the Dalai Lama, I don't know. This is aspirational. But in fact, it does help to have a little bit of it as a little energy perk when you're dragging. Move back into that focus of I can't do this, but I can do that. And this is about the other. And the wish to relieve the suffering of the other really is such a counter force, if you will, to burnout. Now, you might ask, as I found myself often asking, well, as I was reading Agnes's book, well, if compassion is so great, how come we don't see more of it? If it is innate and it would be so good for us, then how come we don't do more of it? Well, there are lots of barriers to compassion, and there are some really interesting studies. This is one of the real closely this is an area of research in which there has been a lot of attention in the last couple of decades. Time pressure is one very real barrier to compassion. It perhaps shouldn't surprise us that that's the case, but I think Anne and I are going to give you some examples of why that needn't be as big a barrier as we tend to think of it, particularly in the long-term care setting. Another barrier to compassion is simply the scale sometimes of the suffering, that we become numb when the numbers of dead get up in the hundreds of thousands, as in the current conflict, or the millions, as in COVID. There is a kind of psychic numbing that sets in because it is hard to take in. And again, these barriers are not meant to say that we shouldn't have numbing. Sometimes we need that kind of mitigation. Sometimes we can't take it all in. It's okay for our brains to spare us a little bit of that suffering. To do otherwise would be a little masochistic. So it's not that numbing is bad. It's that we need to know that that's what's happening when it's happening. The other barrier to compassion, particularly for people living with dementia, is this notion that we can't change their suffering because it's their dementia. It's just the dementia. That's why that happens. That's why they're suffering. That's why they're behaving this way. And I'm going to give you some examples of why I think that is not true. Fear is one of the biggest barriers to compassion in us, for all of us, and it is one that is in overdrive at the moment and has been for the better part of a couple of years. And you can see some of the other barriers that have been studied as well. There are also barriers to receiving compassion from others. I can't tell you how many times I've spoken with staff who say, oh, I don't receive, I'm a giver, I'm a giver, I'm a giver. As though to receive is somehow weaker or somehow not as good. And that's one psychological construct of those who see themselves as only giving and never receiving, or only feeling as though they can only give. And for people who study this very closely, think that one of the challenges for receiving compassion for others is that it makes us feel somewhat vulnerable. And it also, for many of us, can activate grief. And many of you might experience this watching movies or watching certain videos where you see an act of kindness and you find yourself crying. We all have this desire. We all have these little grief pockets left over from perhaps other experiences in our lives, not necessarily traumas, but sadnesses that are not yet resolved. And in the presence of compassion, that can get reactivated. So there's a little bit of keep your compassion to yourself for people who feel very protected and don't wish to have that vulnerability or that grief activated. The other direction that compassion is thought to flow or needs to flow is to others, from others, and then to and from the self. Many people have a very hard time practicing loving kindness meditation that involves their saying, may I be happy, may I be free from suffering. And there is this self-critical tendency among many to say, I don't deserve compassion. Or this very harsh self-criticism, this belief that, oh, I do better with negative feedback than positive feedback, or I benefit from self-criticism because I want to be better. I'm always improving myself. Whatever it is, there are, particularly I would say among healthcare professionals, a very strong tendency towards self-recrimination, towards this desire for and belief in the need to be perfect. And it leads people to a fair amount of self-neglect. Bullying in the healthcare environment and burnout are also barriers to our being able to practice compassion in the settings where they are sorely needed. So that's for your head. Let's take a 30-second stretch break. Look outside. I don't have any sun here, but I do have at least a vast expanse of sky and a lot of green budding trees, well, sort of green, coming up. Take 30. Oops, so I just want to reset yours. So if I may reclaim your attention, let's get back to it. Now, for those of you who work in long-term care, those who work in a healthcare setting, one of the takeaways for this time together this morning is this notion that our residents, our clients, if you're not in that setting, and families are really key to the cultivation of compassion. And some things I'm just going to ask you to think about are, how easy do you make it to move in to your communities if you're in a facility-based environment? How attuned are you to how people are feeling when they come in, when they move in? Or if you work in a home care setting, how attuned are you to what it is like for you to go into someone's private home? However welcome you are, however much they want you to be there. I can tell you that for my own mother, when she went into hospice last year, having 7 well-intentioned people from the home hospice healthcare team show up, one after another, and they were welcome, they were wanted, they were invited in. And after the 5th one, no one was attuned to the discomfort that their good intentions were creating. So we want to always be attending to, paying attention to, attuning to what others are feeling, even when we're trying to, and we think we are, being kind and good and nice and thoughtful and sensitive. It's never about that. It's how it's landing that is important. And we need to think in particular, I think, with respect to long-term care, is even once people are moved in, how comfortable do we make it to visit? I've told you my heartbreak opening story of visiting my friend Janice. And when I went to visit her, there was not a seat to be had that was clean or free, a place for me to sit down. And I've already described to you the conditions that people were living in. This was in a reasonably nice place, okay? It didn't surprise me that no family was wanting to come in. It didn't surprise me that that would have been a hard place, and people were allowed to come in. We were past the COVID restrictions. Everybody was wanting to come in. But there was nothing about being there that felt good or easily felt good to people who were visiting. So I'm going to stop sharing for a moment. And Anne and I are going to turn this into a little bit more of a conversation here. One of my colleagues is going to spotlight us both. We'll get to that in just a moment. But in the meantime, I'd like to ask the rest of you to close your eyes, go off screen if you wish, but to go on a little imagined voyage with me. And I want you to picture, if you work in long-term care, I want you to picture someone moving in to your community. And I want you to do this in a really, really embodied way. I want you to imagine that people are driving up, and let's say that this is a a person who's coming in at the insistence of their family, but with the residents' consent. But they're ambivalent about coming in, even with their consent. And they drive up, and they ready to walk in. There are no steps. It's easy to walk in. But what's the very first thing that they see? Do they see a windowed door? Do they see a glass door? Is that glass door dirty? Is it full of signs about COVID? Again, none of this is judgmental or criminal. I mean, incriminating. It is all to say, what do they simply see? See it through the eyes of somebody who's not going in that same door every day. What are they seeing? Does it look inviting? If there are flowers, are they all dead? If there are flowers, are they thriving? Let's get them in the door. Who's the first person that they see? What is that person doing when they come in? Is that person working on a keyboard, working on the phone, looking up, coming out from behind a desk to say hello? Is that person saying, wait a minute, I'll call somebody to come get you? What is the very first greeting that they receive? How does it smell? How does it look? Is it well lit? Is it noisy? Who comes to get them, to show them to where they're going to be living? What is that like? Do they meet any other residents along the way? Does anyone introduce the family or the residents to the people they pass along the way? And they go into their room. Where does anyone sit? Is there a place for the family to sit, or is there only a bed? Only a bed for the resident to sit on? Are people coming in to say welcome? Are there a lot of people coming in to say welcome? Is it overwhelming? What is the experience of that resident moving in to the place you work? How does the resident look? How do they seem to be feeling? The idea here is to help us all get out of our heads and into that room and into our heart mind, into our body mind, and to say, what would it be like to be a resident here? Now, most residents, in my experience, even in the best of welcoming situations, feel a little afraid, particularly if they have dementia. So no matter how kind or thoughtful we are, from the experience of the resident, they may be clueless as to where they are. And even though we're giving them information like, oh, lunch is in an hour, or what's your favorite meal, or whatever it is, from that person's experience, as often as not, the first emotional experience is fear. And when we know that, we can add into our interventions or add into our approach ways to minimize that fear, to mitigate that fear, to kind of perform our interventions, or to titrate, that's the word I was looking for, to titrate what we are doing. So just the right dose, so that it has the person feeling good about being there, or feeling safe, feeling secure, feeling comforted about being there. So just reflect a little bit more on that moving in while I try to get Anne in here with me. There we go. All right. So welcome, Anne.
Thanks, Susan.
I wonder if you would first introduce yourself a little more than I have introduced you, and tell people a little bit about the work that you do, and then I'll ask you a question.
Sure. Well, I started working in long-term care actually in New York in the 1970s, and I've been working in different aspects of long-term care ever since. But early on, I became an administrator, and so I had about 2 or 3 years of experience of that. And since then, I've worked primarily in quality improvement, but also in sort of focusing on special populations. I spent several years working on helping to create appropriate programs for people who had been diagnosed with AIDS. And then I worked for the city of New York, and they have 5 nursing homes. And we worked also on programs with for people who had mental illness and other complications similar. And for the last 12 or 15 years, I've really focused on dementia. So that's what, of course, brought me to you here today. And one of the things, as you talk about that sort of entry experience, I recalled actually that a filmmaker I know, and I was thinking, I really have to see if I can find it, but they did a film of a woman coming into a nursing home called Home of the Brave. And it's really, and they used a real nursing home to do it. So I'm going to have to see if it was done quite a while ago, but I really itch now to find it. And one of the things when I have talked with staff on this whole process of residents and families entering a facility, and I think I want to say also that it's both that first time, but also in more recent years, I think the pretty much almost equally experience of people moving from short-term to long-term. And I think that gets short shrift a lot of the time because we don't fully always recognize that that can be a harder move than when somebody first came in. But because it's internal, we don't necessarily weigh it the same. And I think it deserves at least that much attention, because that is a moment when something, quite significant is being recognized. You can't turn away from what's happening there. And one of the things that I often find when talking to staff is that a couple of different pieces. One of them is, when we work in long-term care, those buildings and everything that goes on in them becomes as familiar to us as what happens in our own homes. I mean, it's just bred into you, I think. For families, the experience is the opposite. They know they're coming to a place with a lot of rules and they don't know what those rules are. Setting aside, what your introduction about how we're welcome is just that there are a lot of rules and we don't know what they are, and oftentimes the words that are used are foreign. They're not words that we normally would use with our family members. And then finally, one of the things that and I was doing some focus groups with staff, and it was about coming into the home, the person's experience or how they saw it. And one of the things that ultimately didn't surprise me, but it was kind of startling, is that from one unit to the next, there were sometimes vast differences in how they went about bringing somebody or a family and a resident on board. And just to give you a couple of examples, we were talking about ice machines, and a nurse on one unit said, "Oh well, families can't touch it because of infection control. They must absolutely stay away from the ice machine." And I tell them, you can't do that. Another nurse said, "Well, how I do it is I take the family member over, show them where it is, and said, this is, you'd like to know where you can get ice. This is where you can get it." This is the same home, 2 different units. And then another example was on one unit, they said you can't bring a comforter from home because of fire retardation, whereas in another unit, they let it happen. So I say this because had I not been doing this focus group, I mean, this was a good home. They cared about their residents, they cared about family members, they certainly cared about their staff, but it just was one of those things. And I don't think it's uncommon. So it kind of behooves us to keep track of what is our message, what are we saying to people, and that there is often a reason why families get completely confused about those rules, because the rules can change depending on the shift, depending on the floor. And then finally, certainly one of the things that happens in many of the homes that I know well is that a lot of times the admission period, time of day, is after 3 o'clock in the afternoon. And I don't have to tell anybody who works in long-term care that that is, a really complicated time. I mean, it's shift change, it's a dinner, it's often less staff, it's a change in staff. So that all those things are can be impediments to the kind of welcome that we really want to give people. None of it is intentional, of course, but I don't think we always realize the impact on families and residents, because that there is a little more chaos at that time of day. And also I recognize you don't have any control over that, because that's when hospitals send people. So it's not as if there's an easy solution to it, but I think being aware of it is important, because if you take a look around with fresh eyes, you can see how difficult this can be for people.
Well, and you've covered a lot of territory there. The one that really struck me, and I'm surprised it hasn't struck me before, is that transition internally from short-term to long-term. Because as soon as you said it, I thought, duh, and oh, because I think that is something that I hear from residents a lot. And what's interesting to me about that also is that from the resident's perspective, it's still not a done deal. There is still a belief, a wish, a hope that they're still going to get to go home, because that was the contract that they entered with. That was the understanding. That was their intention. And their hopefulness has been centered around that. And what I realize is that it is one of the big suffering points, one of the big distress points for so many residents. And what I more often than not hear people saying, staff, again, good homes, well-intentioned people, oh, this is your home now. As if that makes them feel better.
As if that's automatically good news.
Yes, exactly, exactly. So I wonder if, from your experience, you have found any ways to mitigate the unhappiness around that very specific transition point. Not silver bullets, but just how, or have you found a way to talk about that specifically, or to have a specific intention around that? Any thoughts?
Well, I think the first thing is to understand that it is a big thing, and that I mean, not everybody obviously goes through that process the same way, but for both family and for residents, that is a very significant moment. So just knowing that, understanding that, and then I think to understand that it is also for families. But I would say that the biggest sort of help to that, if it doesn't resolve it right off for sure, is just that as we've learned, whatever we have come to know about somebody's comforts, first of all, making an effort to find out what comforts somebody, and then trying to build that in as much as possible, not only in the beginning, but also at that moment of transfer, so that when somebody goes to a new unit, a new experience, the people who greet them have some awareness of these things. It can be simple things like I understand that you like to watch or I don't like to watch this TV program. And this is obviously not a dementia thing necessarily, but on Tuesday nights, or you really like a cup of tea first thing in the morning, but just to acknowledge those things can go a long way. And it doesn't have to be terribly complicated, but just it's a recognition that you're a person.
Mm-hmm.
You have preferences, you have comforts, and again, not a lot. I have found over the years that those comforts, for any of us, a friend of mine, her mother lived in, I forget what it's called in Oregon, but she was in a small sort of group home, And her mother loved two things. One was a cup of tea about 6 a.m. And the other thing was she loved to watch the news hour. But the family, I mean, they were loving, and it was a great setting, and basically it worked. But this was a family that ate later. So they ate during the news hour and they slept later. So she never got that early morning cup of tea, and she never got the news hour. But those were, if you were identifying them, the two things that she enjoyed. But I do think, passing along, making sure that the receiving staff is aware that these things are comforts, and making that effort to acknowledge and recognize. And then too, I think sometimes it's just depending on the resident, depending on the family, that just acknowledging, yes, that we know this is a big step, and please let us know how we can make you comfortable.
Yeah. Yeah, it's always that asking, right? It's like, how can we, you know, in that welcome, acknowledging that it might not be easy, and how can we make it feel a little bit better? I was reminded when you're talking about comfort measures, one of the things that residents often tell me is just the simple act of asking my name, by what name I like to be called. There's
Right.
lots of different ways of doing this, and making sure that you use my name every time you see me.
Yes.
Kind of like a reassurance that I'm seen. I'd like to ask if there are any members of our audience, any participants, attendees who would like to share anything. If so, raise your hand or speak right up, or do something that indicates. There's also the reaction button down below. You can raise a hand, and maybe Cami and Susan can help me identify you.
Just to add quickly too, that a reminder that the rules change from rehab to long-term. And that's the other thing that we may assume that a
Yeah.
family and a resident understand, but in fact, that's rarely the case. So just another.
Yeah, thank you. Yeah, I'm so grateful for that. You've really just sensitized me to something that I see often, but didn't really make a lot of conscious note of, and I think it really is a very big deal. So thank you for that. Anybody else want to join the conversation? All right, seeing none, let me see what else I got for some slides here, and then we'll come back to me and Ann, and see if somebody else wants to join in. So some of the things that I try to extract from this, or that I hope you extract from this experience, is simply this empathic exercise, if you will, is trying to be sensitive to what family members may experience, what residents, and I think that's what Anne is talking about as well, and also avoiding judgment about the family's decision. You can trust me, they are already judging themselves very harshly, particularly if the parent or the spouse does not want to come in. And these moments are very painful, I think, for family and for staff. And it's important that we not judge either the decision or how people are experiencing their feelings, because there's going to be a lot of different feelings, and they're going to be jumbled. And one of the feelings that families are surprised by and feel a little guilty about is how much relief they experience. And I think sometimes what residents are surprised to find is that they experience relief and resist that for some time. Some people never experience relief and never make an adjustment. So strong was their opposition to the plan in the first place. But when I think about sources of suffering for residents, in particular, I've really emphasized fear. I think also the loneliness that people sometimes experience, the loss. But recently, some residents that I've been talking with have emphasized how unloved they feel. And they feel unloved because they experience themselves as being mostly problems. And many of them are. They're way they express their needs is very problematic for staff, for other residents. It's not that there aren't distress signals coming, but we experience that very differently than the person who, whether they recognize that they're difficult or not, is kind of not the point. That where they end up is feeling quite unloved, unwelcome, unwanted, undesired, and if they're in a long-term care environment, not of their choosing or not their decision, then that sort of immediate sense of rejection is compounded by a sense of rejection from their families. So I've used this phrase distress behaviors or distress signals, distress communications, and it's the way I've come to understand problem behaviors, difficult behaviors, challenging behaviors. Call them what you will. I want to offer you a little reframe on a very common one. One of the things as a geriatric, or one of the situations as a geriatric psychiatrist that I'm often called to address is this notion of combativeness with care, resistance to care. And one of my starting points for residents, or for staff rather, in trying to figure out what's going on, to understand that behavioral communication. What is this person trying to tell you who's kicking, biting, shouting, doesn't want you touching them? What are they trying to tell you? And I like to start with a whole list of guesses we could make, but then just ask people very briefly to imagine what it is like to be a person living with dementia, so that every morning you wake up being afraid. You don't know who anyone is. You don't know what they want. You don't know if you're making sense to them. They're not making sense to you. And so when we do that, when we try to put ourselves into the shoes of the person whose behavior is signaling, leave me alone, our next job is to understand why. We're there to help them feel dry, get clean clothes on, not to eat, to no longer be hungry. Our motivation is positive, and they want nothing to do with us. And you see how easy it is, and I think so many people often do this, is to say, well, that's just what people with dementia do. They're combative with care. It's on the list of common symptoms or signs in dementia. So we don't want to do that. We don't want to say, oh, people with dementia just do that. We want to say, what is this person telling me right here, right now? What is making this, what is a good offering in some way, something I'm trying to do that's good, and they want no part of it. Try to stand in their shoes. And I think that what we often come to is how frightening it is. And of course, if somebody gets a bad reputation, somebody who typically swings or hits, or then we send two people in. It's like the worst thing that you can do, because now they're trying to defend on both sides, as one person's trying to hold their hand while somebody else tries to wash them. The idea in doing an intervention is to start from attuning to what might be going on for that person. Then what you're dealing with is addressing fear rather than addressing resistance. You see how it shifts both the nature of our intervention and the quality of our emotional attunement. And I would venture to say that trying to address the fear has more to do with compassionate care than just trying to find the right medicine or find the right intervention that will get the person to stop doing whatever it is they're doing. And I know this is an area of interest of yours as well. Do you have any comments you'd like to make about what might be triggering this kind of resistance?
Well, I think that fear and pain and are probably the two biggest. And pain can happen simply because they, and not simply at all, but, they're in pain and something is hurting them and you're coming towards them and or you're inadvertently, like, for example, a story was told to me about a woman who they did fine with dressing her until they got to the sweater, and she would really push people away. And it turned out she had an old shoulder injury. Once they figured that out, then they made a strategy for putting the sweater on, and that took care of it. And then there was the man who came into a home having been in a psychiatric unit and in a couple of different nursing homes, and he was combative until they discovered that his wife told them he liked to stay up until 4 a.m. and sleep until noon. Well, he was combative when they tried to get him to go to bed when he didn't want to, and when they woke him up out of a deep sleep. You change that so to accommodate his comfort, and those resistances disappeared, and he was off antipsychotics in a relatively short amount of time. So I think it's really important to, as you say, once you identify it as distress, then it's not what they're doing, it's what you're doing that becomes significant, because you're looking for what's causing it and changing it. When we call it resistance, then we're just trying to think about stopping it as opposed to, and that's where, unfortunately, a lot of antipsychotics come into play, because antipsychotics don't treat pain, and they dull them and dull us from understanding what the distress is.
Yeah, that's so critical. So I just want to underscore it. When you think the problem is resistance, you try to overcome the resistance, and you reach for medications that make people more compliant. And I think Anne is absolutely right that it's an inadvertent use, inappropriate use of inappropriate use of antipsychotics, because you're targeting the wrong, not even a symptom. You've got the wrong problem, the wrong target. You've got the wrong target. So yeah, thank you. I think in this domain in particular, we want to emphasize that fear-based behavior is not psychotic. Fear-based behavior is fear. And so we have to mitigate the fear. When I ask residents this very question, sort of, what would you like me to tell people today? Because I told them that I was going to be meeting with you and that we were going to be talking about compassion and what would look more compassionate to them. Helping me call my family, even when my family has said, I don't want to talk to me, or I don't want to talk to them. Helping to modulate that, mitigate it. These aren't their words, these are mine. But there are oftentimes situations set up where a family member perhaps has been called too often, or at least from the family's perspective, too often by the resident. And so the resident is discouraged from calling the family. The family may ask the community, the facility, the nursing home to help with that. And from the resident's perspective, what happens is that it's not mitigated, it's not modulated, it's not, well, I'm calling 10 times a day, now I get to call 5. It's they won't let me call. So inviting the resident, even the resident with dementia, to be part of the negotiation is always really important. Now, it gets trickier with people living with dementia because they may not remember they were part of the negotiation. That's okay, you just remind them, or you say, let's negotiate this. How would it be if? Oftentimes, some people living with dementia, or not even with dementia, have lost their capacity for empathy. And you might say to a person, as I often do, I know you'd like to talk to your family more, but X is happening. You can surely understand why it wouldn't be a good time for you to call. No, they don't understand it at all. Or not all the time, obviously, but sometimes they don't. And what I find sometimes happens then is that staff tries to compel them to have empathy rather than meeting them where they are and just trying to help in the most compassionate way possible, meet the goal they have, which is to be in connection with family, and to also support the family's inability to, or support the family's ability to take the calls at different times. I can't tell you how many times I have heard from residents in many, many places. I wish people, when they said hello, would say it like they mean it. It feels so many times like, I'm supposed to say hello, I'm supposed to be nice. It doesn't feel warm. And so one of the things that residents recommend is just look at me. If you've forgotten my name, ask me for it. Look at me when you say hello. Say it like you mean it. And if you don't mean it, don't say it. I was very touched recently by one resident who described to me that she is secretly helping her roommate who has had a stroke. And she's doing it secretly because she's afraid she would not be allowed to help. And help in this case is not helping somebody get in and out of bed or go to the bathroom. It's moving something from the dresser, bringing it, a cup of coffee, a cup of tea, whatever it is. Something the person is asking for, pointing to, putting a blanket on. It's not unsafe behavior, and yet she's afraid. And when the resident talked about this having to sneak to be helpful, I can't tell you how many of the other residents said, "Oh, I do that too," because they don't like me helping. And the they, of course, refers to us collectively, the staff. So we really do need to think more about how residents like us have a need to be compassionate, have a capacity for being compassionate, need to enjoy the feeling that you get from when you do something nice for another person. And without exception, residents always say, "Get to know me a little better. I'm not so bad," I think is sort of the way one person has put it. I think you know all of this. I think what I keep trying to understand is how we can all best get out of our own way. And in the last half hour, that's exactly what we're going to talk about. So stretch again, look outside, do what you need to do. And someone by the name of C. Allard, when we come back, I understand from the chat box you had your hand up and I missed it. So when we come back, perhaps you would be so kind as to join the conversation. If this is a she or a he, or so Miss or Mrs. or Mr. Allard, or
I'm here.
let me see if I can find you. There you go. Okay, hello.
Hi. I'm thinking when you were speaking there, when some of my clients were looking at a change of setting, going into a nursing home setting or whatever, I always encouraged the family to bring in something of theirs that showed who they were as a person. I would go into people's rooms. I went in to see this one gentleman one time who was blind, and hanging on his wall were some swimming medals. Another was this beautiful carving of an outdoor scene. None of these things were there for his pleasure because he couldn't see. But when I went into his room, I said, look at the medals on your wall. What are these for? Look at this beautiful thing on your wall. Did you make this? There were several things in that room that told me this wasn't just this little old gentleman in a recliner, couldn't see, couldn't motor around. This was an interesting person that had a history. And I got into some really interesting conversations with him about the things that were in his room. And it struck me that it affected me that way, but also the people that are caring for him can come in and see this person. This is not just an elderly man who needs care. This is a fabulous individual who has a lifetime of experience and things going on. And I felt that I knew him a bit by just looking around his space.
I think that's such a good point, and that you make about this wasn't just for him. This was for me. This is so I would know him when I came in.
And the staff.
So other people who lived there.
He had value. He had value.
He had a story.
Yes.
He had a life. There were things. And the thing that I like about those personal effects in rooms is that it gives you something to talk about.
Yes, it does.
I'm not that good at small talk. And I'm always so grateful when there are like clues around that I can say, oh, tell me about that. And so I think you make a really, really good point. You know, for a long time in memory care units in particular, and this is the non-compassionate way to do
I'm
what you
frozen here, I guess.
described. Sorry, I'm frozen? Did, oh, thought I heard a
My
cat.
internet connection is unstable, so I keep losing. I keep
Okay.
losing.
Okay. Um, well, what I wanted to say was that, um, I like what you described. What I wouldn't want it to become is everybody gets the same box on the front of their door to put their memories in. Like it's almost as soon as you get a compassionate idea, Michael's turns it into a craft. And then as soon as somebody likes it, everybody has one and everybody has to have the same thing to get this sort of uniformity. And it's not that it's bad, it's that it becomes impersonal. And so I think that the message here is to keep it super personal. If you like those memory boxes and those things on the wall, they're nice, but they do have a way of then becoming kind of rote. And what we're trying to do here is to keep things from becoming rote, to use empathy to prime our compassion. And empathy requires being with the other, seeing the other, feeling into the other where they are. So here's the next group I'd like you to feel into, and that's the staff themselves. I've invited you to think about what it would be like to be that person living with dementia, always afraid. But I've been thinking lately about what it would be like to go to work every day, sometimes having to work 2 jobs in order to feed your family, and to always be afraid, to not know if you were going to get COVID that day, to not know if you were going to be spat on, kicked, hit, or experience a re-traumatization. About 75% of our long-term care workers have a history of trauma in their lives. And so since my visit to my friend last January, I've tried to put myself in the shoes of the staff as well. And I have found that fear and feeling unloved and unvalued are strong feelings for staff, or as strong of feelings for staff as they are for many residents. And so I'm kind of making it my business to help staff feel less afraid as well, and to remind staff of the importance of their mission, the importance of the work that they do, so that instead of being mad at them for being lousy, uncaring workers, I now approach the problem from the standpoint of what are they afraid of? What are they not feeling appreciated by? And it's not just that they feel fear, it's not just anything. It's a shift in the frame of reference that reminds me, and I hope reminds all of us, just how hard it has been, what we've been going through, and it's not over yet. The world's a particularly unstable place at the moment, and this is the reality. Just as people are beginning to enjoy being away from COVID, or thinking we're getting out of COVID, we're worrying about new spikes. So these are particularly troubled times, and particularly difficult times for us, I think, in human services. And I was going to pivot here to a little bit of talk about stress, but we don't have time. So I'm going to move right on to burnout and talk to you about how I use the term burnout, because it's more than being tired. It's more than being overwhelmed. It's more than just being anxious. It's really a feeling that we can't do our best, that we're not doing our best, that we feel overwhelmed, and we will inevitably shut down in the face of that, and it's a feeling shut down. So that to me is a more workable definition of burnout. And ultimately, we tend to lose sight of what matters most, why it is we're doing what we're doing. And when we can get back to that, when we can turn off the fear, then we can begin to approach our own risk of burnout from a place of much greater compassion. Now, I was going to break us into breakout groups right now, but it is 1:15. So instead, I'm going to ask you to please put in the chat any strategies that you adopted during the pandemic, still adopt. What are you using to deal with your own stress and to help your coworkers? What have you found helpful? Just a word or two, a phrase or two, and we'll highlight them or try to summarize them at the end of my remarks. But I do want to get to talking more about compassion as an antidote to burnout, and to leave you with 3 practical strategies for cultivating it within yourself and within your workplace. But please add some things in the chat as well. So I'm often asked when I turn my attention to staff, is it really possible to train someone to be nice, to smile like when they mean it when they greet a resident? How do you train someone to show care and compassion? How do you train someone to be nice? And what I find myself saying is it's not a matter of training, it's a matter of do unto others. It's a matter of treating your staff the way you want them to behave towards the residents. It's a matter of the golden rule. And a rephrase of the golden rule I've heard recently that I really like is this: don't do anything to anybody that if it were done to you, you wouldn't like it. It kind of shakes it up a little bit from the just like the be nice, do unto others. Oh, we've all heard it. But have you heard it that way? I hadn't. Don't do anything to somebody else that you wouldn't like done to you. Don't do anything that would cause another pain if it would cause you pain if done to you. And it kind of gives you a little bit more pause than just the old golden rule. It makes you think before you act. And that cognitive piece of compassion is one of the ones that we have to awaken because it has been dulled in the face of a little bit of psychic numbing, because there's almost been too much for us to take in these last couple of years. And we need to find some ways to mitigate that and awaken these other attributes, these other capacities, our innate capacity for compassion. Remember in the seeing of residents, the seeing of each other, the seeing of the traveler, that you both welcome and resent, that nobody wants to be a label, nobody wants to be a number. All of us want to be seen for who we are. We don't want to be named by our disease or disorder, for sure. We don't want to just be known by what ails us. We want to be known by who we are. We need to apply this to one another, as well as applying it to residents. A shorthand I have for this is work on taming your fear and waking up your mind. This little pink part up here, the prefrontal cortex, is the seat of compassion. And here's how we awaken it. Gratitude practice has one of the best, it has some of the strongest evidence of being able to awaken compassion in us. And again, I just don't want this to be a bumper sticker. I'm grateful. I don't want everybody going out and getting gratitude rocks. I want you to have a gratitude practice that is meaningful. And why do I want that? Here's why. 8 good reasons for practicing gratitude. That really elegant study done after 9/11 showing the benefits of gratitude. Those who had different experiences in the post 9/11 world in terms of their own resilience to that particular tragedy. So this is why I want you to practice gratitude. It's good for you. It'll help you sleep. It'll help you it'll improve your physical health. It reduces aggression. It increases empathy. You can read for yourself. But positive emotions in this crisis are what we need, and it starts with gratitude. Few ways to do it. Lots of people like to write journals. I am not among them. But I do like to keep notes. I like stick-it notes. And I do like things. I like rocks when I walk the beach. I like a particular shell. I put my gratitude on it. I toss it in a jar. You can toss a piece of paper. You can toss a rock. You can toss a stone. You can toss nothing at all. Keep a journal, write it down. You can just say it aloud to yourself and keep it keep it at hand, so to speak, in your head. But the important thing about gratitude is to take it out of the aphoristic, take it out of the trite, take it out of the too easy, and put it into a daily practice, not unlike a meditation or a prayer, that says, I am grateful for X, and here's why. And here's who's responsible for that. And if it's another person, you thank them. And if you have a faith-based life and you believe that good things come to you from a higher power, then thank your higher power. But thank someone, something, thank the natural world, and say it, write it, note it, make it real, not trite. That's how you get these benefits. Not from, I'm just grateful for everything, okay? Make it real, make it specific. And again, if it's for another person that you're grateful, tell them. The second thing that will help you enormously cultivating compassion is something that cognitive behavioral therapists call catch, check, change, or you'll sometimes hear it as catch, challenge, change. It goes something like this. When you hear yourself focusing only on the negative, when you hear yourself say, nothing good ever happens to me, she always does that, this always happens, never good, always bad, you catch it. And some people actually literally add a catch. I catch that. Okay? I don't usually do that, but I do catch myself a lot. Saying things that are only half true. And then I check them and I say, is that really true? No, sometimes good things happen. Is that really true? When I was sitting in that day room so fuming, is it really true that not a single person walked by and said hello? Almost, but not quite. It was not no one. And so you catch it, you catch yourself. You check it, and then you change it. And you say, usually after a deep breath and a sigh, there is some good in the world, or this good thing did happen. Or no, it's not always true. Sometimes this is true. And it's one of the most powerful ways for beginning to tame our fears, our self-recrimination, and create, or remove rather, one of the barriers to compassion within us. So catch, check, change. Now, it's funny, I recently gave a talk at Leading Age, and I used this as an example. I have created a curriculum around recovery from the pandemic, and used this as one of the skills that I've been teaching to CNAs in a number of different homes in Connecticut. And they really like this one. That catch, check, change is very popular. And so I used it at Leading Age as well. And afterwards, a couple of people came up and said, I'm going to teach that to my kids. And when they do it, I'm going to catch it. Well, here's the thing. I should have told them then, I forgot. You don't do this for somebody else. You don't say, you see how negative you're being? No, that's like the worst thing you can do. But you can say, when I find myself thinking like that, here's what I do. I don't know if it'll help you, but you don't catch other people out being negative. You only catch yourself. You catch yourself, you check it, and you change it. And it is a wonderful way of actually getting hold of your mind, particularly if you work in a difficult environment or work around difficult people. Catch yourself, your attitudes, the assumptions, the prejudices, the biases you have about that person or those people or the work situation that you're in. Catch it, check it, challenge it, and change it. And it really removes a big barrier. And
well, no, I was just laughing because a friend of mine who is a wonderful coach on so many levels, and many years ago, it's a little thing that I do with catching myself, which is that you might make a statement and then go on to say, but, blah, blah, blah. And I switch it to and. And it just helps me stop for a minute and think about what's the most important message here, I just love that because it's probably 15 years ago that you taught me that, and I still do it. I still pay attention. So
yeah. And great example. Thanks for adding that, Anne, because that's the thing. It's about paying attention. And what you find is that when you pay attention, that that innate capacity blossoms, right? I mean, that's the thing we have to get out of our way. Thanks. Anybody else have any tips like that to add? I see the chat box is filling up. Thank you very much. And keep those comments coming there if we don't get time for them here. Pause for a moment in case anybody wants to speak. All right. Last skill, last strategy, and this is the cultivation of something known as loving kindness. All religious traditions have this, and the guy to the right is the Dalai Lama, if you don't recognize him. The box in the middle is people from a Christian faith have lots of representations of loving kindness and a loving God in religion. And to the left there on my screen is for the secularist, so that I can remind you that loving kindness is good for your brain, even if you don't have or believe in a higher power. You don't need to. Loving kindness is not about religion. It is human business. It is not a luxury. It is a necessity. That's from the Dalai Lama. Those are not original with me, but I love those words. I've added for you in this slide deck an absolutely wonderful 10-minute guided loving kindness meditation that you can try out. I've listened to a lot of them online. I've curated it for you. This is a really nice one, I think, that is not imbued with a lot of the trappings, perhaps, of some traditions that may be too foreign, whether it's the music or the sort of cadence. This is a really lovely 10-minute guided loving kindness meditation for yourself and others that I urge you to check out. If you like it, build it into your daily routine or your weekly routine, whenever it is, because it is a very, very potent way, and I've got the neuroscience to prove it if you want the articles, to awaken compassion and to get your frontal lobes back to work. Before we stop, I'd like to give you one last poll, if I may. And here it is. I'd just like to know whether you're going to do anything. It's okay if you're not. I think it is likely I will have some conversations about compassion. I think it's likely I won't do anything. I think it's likely I might try that gratitude practice, or at least one of any of them. So, and thanks, Cami. She's put that YouTube meditation in the chat box as well. And it is just about 1:30, so I am going to close the poll, even though we're not up to the usual number, but about 70% of people have voted. There we go. Somebody kicked us over 70. Thank you very much. And look at this. What wonderful participants you are. Everybody's going to do at least one thing. And really, that's all that matters, is to just give it a try and have a conversation, try an exercise, practice gratitudes. I promise you, absolutely promise you, you will be better for it. You will feel better for it. Not be better in some moral sense, so you'll be a better person. You'll be happier. And so won't the people around you be. So I thank you very much for coming. If you'd like to continue the conversation, please stay in touch. These are some ways to do it. And Anne, last word goes to you.
Oh, well, I agree completely. I think that gratitude as a practice, which I've worked on more deliberately over the last few years, and I think it's made a big difference in my life, for sure. No question about it.
Thank you very much. And thank all of you for coming. Thanks for participating. And thank you for the kind remarks in the chat box. Keep those coming too. And we'll hope to see you in grant year 4. Cross your fingers that that we are funded again, and we will continue our efforts to improve dementia care and our overall compassion. Thanks again for being here.